action. May not work ideally, but this is what it should be. So decompress the antechamber first. Yeah.
Absolutely. So misdirection syndrome. Now, usually we have already talked about different causes of iris prolapsing. So I would be talking about an endogenous cause in the form of fluid misdirection syndrome. So how does it typically present with? Well, you will find what is happening is that the surgery is going on in a very uneventful way. And you would find that more or less, not always, these are the hyperopes who are more prone. You will find that at times there is some bit of rhexis extension, but there are quite a few situations where the rhexis is intact. What happens most probably in these cases is that there's a lax zonular fibers which allows the entry of the BSS through into the posterior segment. And when does it happen? It doesn't happen at the very outset. It happens near the end of the surgery when you suddenly find that the AC pressure has started rising. The anterior chamber has started shallowing and the iris has started to prolapse. So now this situation, what is the pathophysiology? The pathophysiology is that BSS percolates into posterior segment. There is accumulation of fluid in posterior segment. There is an increase in posterior pressure. Forward displacement and raised anterior chamber pressure are the sequelae which are involved in it. So what needs to be done at this stage? You need to stop. You need to look. You need to listen. Listen what? Listen whether the patient is in pain or not. And then you have to act. And what are the external causes which immediately should be looked into? Like lid speculum, as has already been shown. Drapes at times. At times it's so happening, if you have given a retrobulbar block, there's a slowly progressing, slowly evolving retrobulbar hemorrhage. And there was once when I saw that the patient was okay, and when I took off the drape, I realized that the patient had some bit of retrobulbar hemorrhage, which was causing the the increase in pressure. And the endogenous causes in the form of fluid misdirection syndrome. Well, if there's a suprachoroidal leak, you don't have to do all these things. You have to observe and act as fast as possible. Now the question is, what is the management? As the most important thing is, if you have opened it up, then you have to close all incisions, observe, examine the posterior pole. Well, most of us here would not be into that state of mind where because we all primarily are anterior segment surgeons, we don't have a posterior segment help at that point of time. So you cannot do that. But all that you have to see is whether the pressure has risen suddenly, or is there any red glow, which is red, coming up, or a dark shadow which is coming up. And then you have to decide whether you have to use mannitol, do pars plana minimal vitrectomy, definitely after excluding suprachoroidal hemorrhage. So we should know what are the differentiating signs of fluid misdirection syndrome and suprachoroidal leak or hemorrhage. If it is a fluid misdirection syndrome, it has a slow progression. It is typically painless. There are some ocular risk factors which may be there or which may not be there, because there may be occult zonulopathy also, or there may be some laxity in the zonules which may be causing, and if it happens to be a suprachoroidal one, it is usually fast onset and progressive. Systemic risk factors are usually there: hypertensive patient, old patient, prolonged surgery, painful at times. The patient says that he's having pain, and appearance of a dark shadow. Let's see this video. This is a very old video which I could find. Here you will see what is happening is, can you switch off these lights so that it becomes more visible? What you will find is that the phacoemulsification has progressed normally. Suddenly what has happened is that while I am doing the irrigation aspiration, I find that the posterior capsule has ceased to be concave. It has become flat, and it is becoming progressively convex. So you will see now what is happening is the moment I take it out, you can see the burp of, the visco. You will again find the burp of visco. So this shows that there is something which is happening. Either it is, I'll see the speculum, I'll try to release it and try to, you see the pressure is on the higher side. So what I did at that is a very old video, I just put an IOL to see what has, and you can see now still that the pressure, that the iris has started coming out. I'm again trying to release the speculum, and then trying to, reposition the IOL, but the iris is coming out, the pressure is on the higher side. I did not have, the posterior segment help at that point of time, as most of us don't have. So I'll just try to press it so that I can release some bit of OVD from the side port, trying to do, which is not possible. The patient was slightly uncooperative. That made me feel that the patient might be having some suprachoroidals because it was turning out to be painful. But since so I'm just trying to, depress it. I could not take through the side port because the chamber was totally shallow at that point of time. Now tapping the roof, I thought at this point of time that I'll just leave it here, put some air if I can, making an effort to put air, which is quite an effort at this point of time. So what I'm going to do now is I'm going to see if somehow I can do it. I'll just remove it. I'll have a posterior segment view. There's an Osher lens which is available, which can be put on the, and then you can see the posterior segment. I've not used it. But then, you can, the air is there. Now what is the next thing which is going to happen is that I'm going to close it, get the posterior segment examined, you'll see, and come back after some time. And once the posterior segment anomaly has been removed, now you will find and using mannitol has been used, now the pressure is practically normal and the surgery could be completed without any hassle. The IOL was placed back and the surgery was completed. This is another video courtesy Dr. Bhattacharya. So now what is happening is the pressure at this point of time has started increasing. There will be some difficulty in placing the IOL in the bag at this point of time because the pressure has started rising. The posterior capsule is no longer concave. It has become flat or it has become convex. So this is something which is, the pressure is not soft, it is on the harder side, trying to just push the IOL into the bag so that once it is there, then you can see now the iris is trying to come out. There's difficulty in IOL being placed in the bag. So next step is, at this point of time, since here also there was no immediate facility to examine the posterior segment, to rule out the suprachoroidal hemorrhage or effusion, recovery room, 100 cc mannitol, indirect ophthalmoscopy. Once that has been ruled out, now you can go through the pars plana. Dr. Suvain, you showed it in ASCRS, if you remember. A similar, yeah. So
I've got a lot to talk about.
Has been done. The eye will become soft and the procedure can be easily completed. So now you will see that without any problem, things have been done. So questions now.
Let me have the lights.
Suvain, if you remember.
Yeah, I remember.
Losing a battle but winning a war. That was.
Yes, that was the topic. And coming from there, can I see a show of hands? How many of you have had an expulsive hemorrhage? Good.
Oh.
So if you've not done enough surgery.
Yeah.
I've had my share of expulsive hemorrhages. I have saved eyes. I have lost eyes. I have saved others' eyes. I have lost my own eyes. So I've had fluid misdirection. I've had the whole spectrum. Probably I take up more Ganda cases than others. It's become more risk averse these days with all that's happening, doctor bashing. So now I'm having less of it, but still once in a while. So I would look at it this way, like Dr. Rohit said, that yes, I have had this. I've learned from hindsight wisdom. Hindsight wisdom is, I think, pretty relevant over here. All of us, our main focus is to put in that lens any which way. Otherwise, we just can't go back home. My wife will not let me get in. That's the kind of mentality we have, you know. If I don't put that lens, I've lost a battle and I just can't go back home. Muh dikhane layak nahi raha. Get that out of your mind. I have lost even 6 months back, I've lost an eye because the same ego and adamant attitude. And still I don't learn. We don't learn. It was a bad case. So, same as Dr. Rohit showed. Actually, I was using iris hooks in that case. It was a bad case. That was one case which I used after a long, long time. But AC became flat. I thought it was fluid misdirection. I wanted to finish it. Put in the lens and my PC went. Then I realized the choroid was in the midvitreous. So, now I was dealing with an expulsive, and this was a total mess, and I did salvage. The lens was inside. I removed the single piece lens. Again, adamant that you are, put in a multi-piece lens. Vitrectomy. You do vitrectomy, the expulsive is increasing. It's a comedy of errors. So, I would say one simple take-home message, any which way, just close that eye and forget about it for the next 2 hours. Only 2 hours of patience you need.
And you have to underplay.
Underplay.
To the patient's attendant.
नहीं कुछ बोलने की ज़रूरत ही नहीं है. We have had to abort midway. We will reassess after 2 hours and we'll take a call.
Because if you have the confidence.
Because if you have screwed up, there's no going back.
If you talk in the nice way to the patient's attendants, making it appear that in a few percentage, the best thing for the eye is that we put the lens afterwards.
See, one thing I've learned in life is, if you want to get a message across, just tell the other party what his interest is. Simple. What's your benefit? If I had continued with the case, I would have lost this eye. So in your interest, I have postponed it. I'll take a call after 2 hours. Khatam hogi baat. That's the same thing. Dealing with every patient in the last 30 years of practice, I've just realized, tell him what is his benefit in every call that we take. It's not my money, it's not my time, my list, nothing. It's your eye. I've taken the call in your interest. If I had gone on with my ego, I would have lost this eye. So I'm taking 2 hours from you, I'll take a call. I'm not saying I'll do it after 2 hours. If I think the condition is favorable, I'll go ahead today, or I'll postpone it for 1 week. And I did that in that case which I showed in ESCRS. I lost that battle. The family was good. I told them, I don't have a B scan on the table now. So I'll get a B scan done tomorrow. You do the B scan. In fact, the B scan was not in my facility, so get the B scan done elsewhere. Got a B scan done. And the beauty is, next day you'll find nothing on the B scan. If you do the B scan right, then you will probably see a suprachoroidal or a effusion or something. But 2 hours, 3 hours later, you'll see nothing. It's all gone. So that's how I think it's best is to defer, whatever stage you are, and postpone that IOL implantation. If the PC is intact, you can do it any day. You can revisit that surgery, do it free of cost, don't charge anything. It's a difficult thing for patient. And I mean, if you want to comfort the patient, the next day you just put a plus 10D and show him, bhai dikh to raha hai. I just need to put this lens inside. The cataract is out. So that should be the take home message.